Morning. So I'm Sanne Magnan. I am the co-chair of the Institute of Medicine's Roundtable on Population Health Improvement. Welcome, everyone, to today's workshop, and especially to our esteemed speakers. Today's meeting is being recorded and webcast, so we want to welcome those who are watching via the web, and we plan to take questions and comments from you as time allows. Since February 2013, the Roundtable has provided a trusted venue for leaders from the public and private sectors to meet and discuss opportunities for achieving better population health. The Roundtable's vision is a strong, healthful, and productive society which cultivates human capital and equal opportunity. This vision rests on the recognition that outcomes such as life expectancy, improved life expectancy, quality of life, and health for all are shaped by many interdependent social, economic, environmental, genetic, behavioral, and healthcare factors. For our nation to achieve that vision, robust national and community-based policies and adequate and sustained resources will be required. As one of its major activities, the Roundtable sponsors workshops for members, stakeholders, and the public to discuss the importance of improving our nation's health. Today's workshop is about framing the dialogue on race and ethnicity to advance health equity, to advance population health. Equity is central to improving population health because, as our co-chair emeritus, Dr. David Kindig, has observed on several occasions, and I paraphrase him, you've got to increase the mean and close the gaps in life expectancy, improved life expectancy, and other health outcomes. Increase the mean and close the gaps. I also should add that this workshop is taking place in the context of a large body of work at the IOM and the Academies that has highlighted disparities and pointed the way towards achieving the goal of health equity. This includes 3 ongoing activities in the board on population health and public health practice. 1, the Roundtable on the Promotion of Health Equity and the Elimination of Health Disparities. 2, the IOM Culture of Health Committee on Community-Based Solutions to Promote Health Equity in the United States. And 3, this Roundtable on Population Health Improvement. We, as a sponsoring Roundtable, are especially grateful to have had the participation of colleagues from the Roundtable on Health Equity. Phyllis Meadows and Jillian Barclay, who both are members of both Roundtables. Now, for you tweeters out there, please use the hashtag #PopHealthRT as noted at the bottom of the agenda. If you have logistics questions as the day goes along, please talk to our staff at the registration table or those in the room. Note that meeting materials include slide sets given to staff in advance. Other materials will be posted to the meeting page after the workshop. Finally, I would like to thank the members of the Planning Committee for this workshop. Phyllis Meadows, Lourdes Rodriguez, who co-chaired the committee, Jillian Barclay, Martha Gohl, Sarah Linda, and Vish Vishnawat. It was a pleasure to work with such a fine committee. Now, at this time, I'd like to introduce Phyllis Meadows, Associate Dean and Director of the Office of Public Health Practice and Clinical Professor of Health Management and Policy at the School of Public Health, University of Michigan. She's also a Senior Fellow at the Kresge Foundation, and as I previously stated, she's a member of both of the Roundtables working on health equity. So with that, I welcome Phyllis.
So good morning. Thank you. On behalf of the Planning Committee, I want to thank you all for joining us here this morning. I've been asked to take a few moments to set a context for our session today, and more importantly, to share briefly a few thoughts to frame the underlying context of this session, and realistically try to answer why this topic, why now. The Roundtable on Population Health Improvement has engaged over the last several years its members and national experts to help us better understand the varied dimensions of population health, the sectors that might be impacted by population health, and the systems and strategies to achieve health outcomes for our unique target populations. We all serve a variety of audiences. These audiences differ whether we speak of a hospital health system's patient base, a community health center working in medically underserved area, or even a local health department who has a legal jurisdiction in a service community. Although our lens differ, the characteristics or how we define the populations we serve, those groups who need our interventions most, are fundamentally the same. These are the groups that determine the extent to which we can really achieve health and achieve positive health goals. Excuse me. These groups are the people of color, living in marginalized communities, void of resources and voice, case in point Flint, and though aptly and amazingly resilient, have historically been predisposed to social and environmental conditions that have resulted in persistently poor health outcomes for over the decades. So much so that the extent that race, culture, zip code, ethnicity become a proxy for poor health. Today's session is not about reinforcing what we know about health disparities or health inequities. In fact, we worked hard in the Planning Committee to ensure that our program did not present more of the same. Today is about exploring some of the most fundamental issues that have challenged our ability to address the inequities that we've seen over the years, and to go a little bit deeper in talking about and perhaps learning about the underlying issues that have for decades resulted in poor health for some Americans. This poor health has existed regardless of our efforts, regardless of our knowledge, our technology, in spite of our research and new ways of describing the problem. Today's session is a recognition that we have truly missed something, or perhaps avoided something very important. And we believe that this important thing, if not tackled head on, we will all continue to be in collusion of what I call a collusion with the idea and acceptance of failure. Today sets the stage for an important dialogue about the structural, institutional, and perhaps behavioral beliefs and conditions, and of course, those policies and practices that have adversely influenced health and limited our ability to achieve health equity. In 1988, in one of the most widely cited reports by the Institute of Medicine, public health was defined as what we do as a society to assure the conditions so that all people are healthy. That all people, not some people, not all people some of the time, or some people more than others, but all people are healthy. Underlying this definition, and when it's implied in it, is that health is achieved through action, is what we do as a society. Today's session is embedded in action. The title is Framing the Dialogue on Race and Ethnicity to Achieve Health Equity. So why this, why now? Nearly 30 years since that report, many reports later on how to improve population health, we have not moved the needle. That's why. We still have health disparities. We have growing disparities, growing inequities. We have not met this charge. We have failed. There are some who believe we need to change the narrative on what it means to promote health. As a planning committee, we believe it's going to take much more to not only change the narrative, but to define and lift up the appropriate narrative and the appropriate conversations. We began today with what we hope will be a first step in that direction, with a goal of starting a level of dialogue and discourse that will prepare us to reframe our thinking, deepen our understanding, and build more grounded solutions. We know the impact of race, culture, and ethnicity when describing health inequities. And in fact, we have very little difficulty describing these inequities based on race, culture, and ethnicity. Excuse me. But we want to move beyond these descriptions to actions. This will require, without a doubt, that we not only look at race, but we look at racism. That we not only look at culture, but we must look at culture elitism. And we cannot just describe problems based on ethnicity. We have to also look at ethnic bias and the role these current realities play in shaping the resources, the policies, and the practices that limit our capacity to achieve ultimate health for all. This is the beginning of a long journey, and it's a difficult journey. It's easy to talk about the facts. It's hard to talk about how these facts play out in reality. So we start today with these objectives in mind. Today, if we're successful, we're going to explore a shared framework for applying the lens of race and ethnicity in talking about health equity. We're going to look at some of the policies that impact the health inequalities that we see. Communication is key, so we're going to spend time talking about the best practices and hopefully leave you, our participating audiences, with a few more skills and capacity to be more mindful about how we apply the lens of race, to have a consciousness and a conviction in moving these and addressing health disparities. So to begin that process, I'd like to introduce our keynote speaker for this morning, Gilbert Gee, who's a professor with the Department of Community Health Sciences at the Fielding School of Public Health, University of California, Los Angeles. Please join me in welcoming Dr. Gee.